Ready? Can we give ourselves a big hand of applause, a big round of applause for just coming today? We appreciate you traveling from the many parts of the world. I know some were not able to join today, but thanks to technology, we can still connect to them online. Okay, without further ado, let me introduce to you the moderator for our session 5, who is the Director of the Division of Health Systems and Services from the Regional Office of the Western Pacific of the World Health Organization. Join me in welcoming Mr. Luis Viñals Torres.
Thank you, Aliyah. Good morning, everyone. Magandang umaga, because we are in the Philippines. It's a great opportunity. Again, thank you for giving the role of moderating this session. Let me share a few reflections before I walk through what we will cover in this session. First is why this session came about. Now, when we were thinking about the program, and the fact that triggered this was we heard that in some country, which I will not mention, doctors were resisting AI implementation because it's going to affect the way that they were seeing it as a threat to the way how they are reimbursed. Because if AI is the one doing the job, this might end up soon being somewhere else to get paid rather than me. That's what triggers the interest. We need to bring that perspective into study further. And the second thing in reflections, which I shared with a few of you yesterday, is when you look at what are the drivers of underperformance of health systems, most of the time it's not technical problems. It's not lack of capabilities. It's not that, you don't have a good group of great thinkers that know what the problem is and they know the solutions. The problems normally comes from power dynamics, and it's the political economy that explains why some systems are struggling to move on the ladder on the performance. So that's one of the points that when we were reflecting about this session is I don't think that AI will be different. It's not that the fact that we are putting into the hands of practitioners and people and a fantastic tool might not translate into better outcomes if we don't understand the incentives and who wins with the efficiency gains and who capture the efficiency gains and what are the power of the different actors and what are their position. And I know that perhaps there is a lot of hungry in this, including myself, about to learn more about AI and how to do it. But I think that it's worth to have to put some thinking into that. Okay. For that, we have prepared, I think, quite an exciting session, which will be started with my colleague Annie Schuf. She's the coordinator for health policy and strategy at WHO Western Pacific Regional Office. Annie will help setting the scene a bit, just to frame the discussion, what we are talking when we are talking political economy of AI in health. And later, we're going to have two presentations. We're going to travel a bit around the world. We're going to start in China with Dr. Ziwen Miao. She's the acting director of the National Health Commission in the People's Republic of China. The National Health Commission is the Ministry of Health in China. And then we're going all the way to the other side of the Pacific, and go to the Americas, and we will have Ms. Jennifer Nelson, the Senior Digital Health Specialist at the Inter-American Development Bank. She's going to join us virtually and going to talk about a very interesting initiative going in the region. And then we have put together a panel where we will get the Dr. Miao from the National Health Commission, and we'll be joined by Clive Tan from Singapore, a very good friend of WHO, to share the experiences of Singapore. And then also Byung-Jong Kong from ADB, also to know how ADB is approaching to this challenge. And then finally, we will also have Chikako let me read it well, Masida from the Digital Agency of Japan, which we were struggling whether she could join us and make the presentation. So hopefully we will be able to do both the presentation and the panel. And then we will have a Q&A where we'll have plenty of time for you to ask the panelists and presenters. And my friend and colleague, Dodo, will be the one handling this last part together with me and providing some final conclusions and wrap up. With that, Aliyah, back to you. Thank you.
How about a big round of applause for Mr. Torres? And now let's move forward to the opening remarks for our day 2, to be delivered by the Director of the Digital Sector Office of the Asian Development Bank, which is a recording will be shown today. Let's join me in welcoming Antonio Zaballos.
You today at the forum on harnessing artificial intelligence for health equity. I would like to begin by acknowledging the leadership of the Asian Development Bank and the World Health Organization Regional Office for the Western Pacific in convening this important dialogue, and to welcome participants from across the region and beyond. We gather at a pivotal moment. Over the past decades, artificial intelligence has rapidly evolved from a promising innovation into a powerful tool already transforming health systems. Today, artificial intelligence is helping clinicians diagnose disease faster and more accurately, supporting public health surveillance, strengthening workforce efficiency, and empowering individuals to take greater control on their own health. And yet, alongside these promises lies a fundamental question, one that sits at the heart of this forum. Who truly benefits from artificial intelligence? And will it narrow or widen existing health inequalities? This question is especially important for our region. While many countries are eager to embrace artificial intelligence, there are real and valid concerns. Issues such as bias in algorithms, data privacy and security, gaps in infrastructure, and the risk of over-resilience on technology continues to shape how and how fast artificial intelligence is adopted. At the same time, the rapid rise of generative artificial intelligence has added urgency. It is clear that we cannot simply adopt these technologies. We must do so responsibly, ethically, and with equity at the center. This is why these forums really matters. Over the next 2 days, this gathering brings together policymakers, practitioners, innovators, and development partners to move beyond discussion towards action. Together, you will explore practical AI use cases that can improve access and quality of care, especially in resource-constrained settings. You will examine what it takes to adopt artificial intelligence safely, from government and regulation to financing and workforce readiness. And importantly, you will work together towards building partnerships that ensure artificial intelligence solutions are locally relevant and inclusive. What stands out in this agenda is its clear focus on implementation, not just what artificial intelligence can do, but what must be in place to make it work for everyone. Because ultimately, Technology alone doesn't create equality. People, policies, and partnerships do. If we get this right, artificial intelligence can help us leapfrog long-standing challenges, extending care to an underserved community, strengthening health systems, and accelerating progress towards universal health coverage. But if we get it wrong, we risk reinforcing the very inequalities we seek to overcome. So the task before us is really clear, ensuring that artificial intelligence is not only innovative but inclusive, not only powerful but trusted, and not only scalable but equitable. Let this forum be a platform for honest dialogue, practical collaboration, and bold commitments. I encourage all of you to engage actively, share openly, and think collectively about how we can harness artificial intelligence to build healthier, more equitable societies across the region. Thank you, and I wish you all a productive and inspiring forum.
Thank you, Director Zaballos, for that opening. Now let's move forward to a scene-setting presentation on what are the key considerations from different stakeholders to be delivered by the Coordinator on Health Policy and Service Design Division of the WHO WIPRO. Join me in welcoming Annie Chu.
Thanks, Celia, and good morning, everyone. It's my pleasure to provide a brief overview of the political economy of AI and health. As we heard from colleagues this morning already, from Louis and Director Zaballos, this is really an interesting area, thinking about the political economy, the implications, how that impacts, at the end of the day, the policy decisions. So I'll briefly talk about what is political economy and why it matters for AI and health. The ecosystem that we talked about yesterday for AI and the key stakeholders involved, including their roles, their incentives, interests, and how that helps to shape AI adoption and governance. And then we'll touch on some of the key challenges, potential risks, as well as principles in the use of AI in health. So what is political economy? It's really about the power dynamics, the incentives that key stakeholders have, their interests, what are some of the interests and why, the motivations, the formal, informal institutions, and market dynamics that help to shape policy decisions, for example. It's about the distribution of power. That's often linked to financial, human resources, capabilities, and people's influence. Specifically for AI and health, this can reshape power, resources, and accountability in health systems. It can also redistribute that decision-making power. And some of our colleagues in HQ are also looking at the political economy analysis with reference to, for example, health financing policies, which is really fascinating because that is thinking about what are the problems that countries are facing? What is then the policy that is needed to then address those problems? How do you map the key stakeholders, their interests, their positions, and then how to navigate within this complex system to come up with a strategy for the overarching objective. So this we've seen yesterday, Mengji has presented on the minimum ecosystem for AI in health. And here we have within that minimum ecosystem, the key stakeholders, a snapshot of some of the key stakeholders, policymakers, regulators, developers, researchers, purchasers, hospitals, health workforce, providers, as well as communities and other individual users as well. We also have development partners. In this room, what's unique is we have many of the key stakeholders here. And not only that, some of you are also representing multiple stakeholders in this ecosystem. So it's thinking about, for instance, as a policymaker, setting the vision, setting those incentives, as well as the overarching vision and direction for AI and health. As a regulator, setting and enforcing the rules, ensuring the population safety and the quality of using AI and their effectiveness and accountability. From the developer's perspective and their role, creating these products, these tools, managing platforms, researchers monitoring and evaluating, providing the evidence, for example. And we also have a diverse variety of users, from individual users to health service provider as a user of the AI tools, hospitals as well from a broader hospital system perspective, and so on. And what is important is really the interaction and the collaboration, the coordination across these key stakeholders, given the sometimes very diverse interests and motivations and incentives that these stakeholders have. So being able to align and come together. Some factors and incentives in shaping AI adoption and governance across some of these key stakeholders, for example, as a developer, being able to capture the market share, being able to scale up the product, having data access, as a policymaker, showing that leadership, the commitment in the digital transformation agenda, being innovative, and also improving the system's performance through potentially AI applications. For example, hospitals as a stakeholder in improving their hospital system performance and integration of services, as well as being more competitive across other hospitals. From the health service provider or health workforce side, potentially increasing your own productivity and the quality of care. But as we heard yesterday as well, there may be also the burden regarding sometimes the adoption of some of these tools actually may not necessarily translate into that increased productivity or quality of care as intended. And from the community and from the user side as well, in having improved access to health services that may be enabled through AI, as well as your own management of health, for instance, and being able to take more ownership of your own health. So some of the challenges and potential risks that we also talked about yesterday as well, but just to touch upon, given that this is such a rapidly changing AI landscape, that the need for the regulatory system and the challenge for that to constantly ensure the safety, the quality and effectiveness of AI in the health sector. Inequitable access. So who benefits? Who, as we had discussed also in the group discussion, what are the costs, the benefits, and the risks? Who benefits? Who bears the cost? Who bears the risk with the use of AI? There may be public distrust without that data protection and privacy measures in place. We'll also hear from countries when they talk about perhaps having that leadership, that ambition, but also needing to build more of the institutional and health workforce capacity to be able to also match that leadership and ambition. And then development of AI tools and platforms for commercial interests as a concern and a challenge rather than overall the public health benefit. Just very briefly, in terms of key principles, which we've already discussed in the various sessions yesterday about protecting autonomy, safety, transparency, accountability, inclusiveness, equity, and so on. These are in the WHO guidance on the ethics and governance of AI for health. which everyone can access online. And the bottom line is really in thinking about the stakeholder mapping and the key interests and incentives, the power dynamics, and how that plays out into the decision making, and how countries use AI for the public health benefit is having that strong overarching governance framework and a continuous learning system to monitor the impacts of AI adoption in health. So have that feedback mechanism, especially given the rapidly evolving societal needs, as well as values and AI landscape. So thank you very much.
Thank you, Annie, for that wonderful presentation. We now move to our next presentation on China's ecosystem navigates developer-provider regulator relationships, to be delivered by the Acting Director of the Center for Health Statistics and Information, National Health Commission, People's Republic of China. Please let's give a big round of applause for Ziwen Miao.
Hello, everyone. It's my great honor to be share and exchange ideas with all of you. And now, today, my topic is the integrate of AI and healthy healthcare. Now, our country is implement the Healthy China strategy. In 2016, the Healthy China 2030 blueprint was issued. And it ordered to establish the world's largest healthcare system and the largest traditional medical system and the prevention and control system. And building a healthy China is one of the overarching goals of achieving basic socialist modernization by 2035. So its strategy objective is to promote health equity. It means to ensuring all people can equitably and conveniently access systematic health services. And to advance the national strategy, the AI is the power. And in 2035, China has issued three important documents. There are the recommendation of the fifth five-year plan and the opinions of the AI actions and implementation opinions of the AI at medical and health cares. It is to elevate the AI development to the national strategy level, and the integration of AI and healthcare is upgrade the stage of pure technology exploration to a new stage of state guide, large scale and industrialization. And our goals is very clear. Towards 2030, the first goal is the full coverage of intelligent auxiliary application in primary diagnosis. And the second is popular AI imagine and decision support in secondary and above hospitals. And the third is the standard and normative system is basically complete. So it defined 8 key application directions to cover all around medical health care. And recent years, China also cooperated with WHO to conduct the biennial cooperation project. One of the studies is to introduce the current status of medical AI development in China. And it is to establish a medical collaboration network. As we show in the pictures, it is used inter-hospital remote consultation and the remote radiological diagnosis, etc., to promote the deployment of high-quality medical resources to the grassroots level and enable remote areas and grassroots people to enjoy high-quality medical services. And also we used AI-assisted primary care diagnosis and treatment, just like the robot, to enhance the diagnostic and treatment capability of primary care physicians. Besides, in the grassroots, healthcare is the priority. And AI also add in the full chain optimization of the entire process of medical services. It is to, in hospital, AI used to diagnosis system can quickly analyze the medical imaging and the medical records, etc., to enhance the efficiency of diagnosing and treating difficult and complex diseases. And also it relying on digital and intelligent services throughout the entire life cycle, realize the full cycle service from in-hospital treatment to out-of-hospital rehabilitation to strengthen the continuous medical services. China's AI-assisted diagnostic system has achieved all around breakthroughs. It used technologies like computer vision and medical imaging segmentation, multimodal large models, and other technologies. It is upgrade the single imaging interpretation to a comprehensive diagnosis. In the imaging and the pathology, AI is widely used in the long noodle and the tumor screening, and in the clinical decisions, AI also widely used in the ECG and endoscope AI interpretation analysis. And also it is based on the laboratory data, medical imagings, and medical history to realize the comprehensive diagnostic recommendations. Also in traditional medicine, Chinese medicines, AI also used to assist the syndrome differentiation and treatment. And also AI is extended to the public service health management. It is provide real-time health monitoring and diagnostic assistant. It helps doctors to find the earlier disease, and also especially it popularized in the digital family doctor models. It can be signed up on the line and intelligent follow-up. So we advanced in the AI and healthcare. Also, we faced some challenges. The first is the bias in the data sample. So bias in changing data of artificial intelligence across various scenarios, and it may affecting the objectivity of diagnosis. The second is the data security and privacy. We all know the medical data is highly sensitive. It's posing maybe the significant risk of leakage and abuse. And also the third is the ethical and the responsibilities. The black box nature of intelligent algorithm may lead to the blurred boundary of responsibilities. So facing with these challenges, our message is clear. So we promote to integrate the emphasis, the equal importance of the development and the governance. The first is strengthen data governance. I think to establish strict standards for the data collection, annotation is very important. And it ensures the accuracy, competency, completeness, and consistency. The second is to improve the level of multimodal data fusion. It integrates such as electronic medical records and medical images, etc., to help our models can become more precise. And the third is promote the construction of ethical and governance to strengthen the ethical evaluation and supervision of the application of artificial intelligence. And the last is the strengthen data security. we used interpretation technologies and access control, blockchain, etc. technologies to ensure the security and privacy of medical data. All above share is the AI and healthcare in our Health China strategy practice. So I think it is the inevitable choice of high quality medical services. So in the future, I believe with the development of our technology and governance systems, all of us can achieve the high quality medical services. That's all I'm sharing. Thank you.
Thank you very much for that presentation. We now move to our next presentation on paving the Pan-American Highway for Digital Health, to be delivered virtually by the Senior Digital Health Specialist of the Inter-American Development Bank. Please let us let us give a big round of applause for Jennifer Nelson.
Hi, everyone. Buenos dias. Good morning. Can you hear me? Excellent. And can you see my slides? Awesome. Okay, cool. So we're going to go ahead and get started. Greetings from across the ocean. It's nighttime here, but I know it's daytime for you all, and we're really excited. Thank you for inviting us to be a part of this really important event, to learn from you all and share a little bit about how we're approaching this in the Americas. So I'm going to talk quickly about an initiative that we have, a regional initiative called Paving the Pan-American Highway for Digital Health, or the Pan-American Highway for Digital Health. And this is really about enabling digital public infrastructure for health, including AI. So it's not just about AI, it's about this ecosystemic approach that Annie presented, and really about the enablers that we need and accelerating them to make sure that everyone has access to health and digital health services, including those that involve AI in an ethical and fair way. And I just kind of want to, why the Pan-American Highway for Digital Health? As you may know, the Pan-American Physical Highway is the longest highway in the world. And about 100 years ago, the countries of the Americas came together and they did something that was an engineering feat that was thought to be unheard of at the time, being able to create this highway from the tip to the bottom of the continent with a small gap that still exists. And this was a big deal because it was really about creating this infrastructure that allowed for more connection, economic connection, cultural connection. And the symbolism of this road and coming together and agreeing upon this is really important to us as we think about connected health across border in our region. And the same way that now you can drive across countries and you don't change your license, you don't have to get out and switch your tires, you don't drive on a different side of the road, like these things we just take for granted, and how that physical road allowed us to have a more connected economy and commerce and exchange of culture and ideas. The Pan-American Highway for Digital Health is about enabling connected healthcare for all and enabling people to be able to know that they have the right to access their healthcare information and to share it with whomever they choose. So no matter if you move from a public to a private provider or a public to public provider, or you move to a new town or barrio, a new city, a new province, or a new country, either permanently or for tourism or for studies, you are still connected. You are still connected. You still have quality of care. You have continuity of care. And the different countries in the region can trust that data. They know it's real, and they know it's trusted, and they know it's real, and they know it's safe, and it's following these certain policies that the countries have agreed to. So in 2023, you can see here, we had the director of PAHO, Director Jarbas Barbosa, and the president of the IDB, Dr. Ellen Goldfein, launched this initiative. And we were so happy that with the support of the government of Japan, our first funder, we were able to make this initiative a reality. So again, as I mentioned, this is really about digital public infrastructure. This is about a shared vision. This is about accelerating that ecosystem that we need for both the public and private sector for regulation and innovation to come together to really deliver value across the Americas. And these are it's to enable value for some of these key problems that we have. Like, we don't have enough specialized care in certain countries, especially in our small Caribbean nations. We have high mobility of our populations. We don't have shared standards and a good access to maybe that international market for health and digital technologies, because we haven't been adopting standards and using them at scale within the region. And we are now at a moment where we can actually access some of this other digital public infrastructure, like digital payments, digital wallets, digital identity, from our e-government sectors to be able to enable the health sector to bring this forward. And what the initiative does is, with the seed funding from Japan, and we're able to leverage countries' national investments to then align standards, do some market shaping across the entire region. So how do we do that? And I'm going to talk about this in general, but then I'll go through and talk about how this applies to artificial intelligence, but you could do this for any technology, emerging or not, about how this works. So at the regional level on the highway, we have to have traffic. We have to have the rules of the road. We have to know what's the speed limit. Do we have to wear seat belts? Are cars and bikes and trucks allowed to drive in the same lane? Like this kind of stuff. What side of the road do we drive on? These are the governance rules that are currently being negotiated. We were very excited that in the last PAHO Directing Council, in 2024, the concept of the Pan American Highway was approved by all the countries of the region, and there's actually a target in that resolution that describes that by 2030, 30 countries will be on the highway exchanging data. So there's a tangible target, there's a commitment from the highest level. We also work very, very closely with our colleagues and friends at WHO to help support the adoption of the Global Digital Health Certification Network. And I'll talk about that in a little bit, but there's a big governance element to all of those pieces, deciding about who's allowed on the highway, when they're allowed on the highway, what data, how it gets used, how are we making sure it's privacy, ethical concerns, all that piece comes into that governance. And we're currently this year signing off on a set of principles for the PH4H framework to enable specific use cases. And that brings us to our next piece, which is looking at cars and drivers. So these are, this information that moves across the highway, the cars, and the people that are driving those cars, be it the population, patients, providers, or policymakers that are using that data. So on one hand, we do a lot of work with countries to define what are those priority use cases. So I'm going to talk about our first accomplishment in a second, really focusing on the digital yellow fever vaccines. But AI is also a strategic car and driver within this system, as well as it relates to governance. And the piece here that I think is very important is countries are coming together and agreeing about what their priorities are. We have a list of currently 15 use cases that have been identified by countries, and we're currently working on that governance mechanism to then prioritize which are the first 8 to go into production. The first was yellow fever digital vaccination certificates with support from PAHO and WHO, and we'll be continuing to work on things like the international patient summary. But that same logic applies to artificial intelligence. So as we come in and we're talking about, okay, how does AI affect the highway? Sometimes AI is coming in at us as a new vehicle, like maybe it's a type of truck that we've never seen, or maybe it's also a new way that infrastructure lays, a totally different type of lane. And we have to think about it as far as a lot of what we are doing right now. We're currently undergoing a study that's looking at how you evaluate risk around AI, so how you can govern this. So learning about best practices from the FDA or EMA and other regions, how emerging health technologies are regulated in general, thinking about that role as far as which of these types of solutions should be on the highway. When they're on the highway, how are they to be used? And this last piece at the regional level, called Paving the Way, is about infrastructure and infostructure. And this is the part of, I would say, of the initiative that's received a lot of visibility. One of the things that has been quite effective is our work with connectathons. And connectathons allow us to have a test bed where we can actually safely test and deploy system conformance. Okay, so we can test to see if the different systems being used by countries align to the WHO Global Digital Health Certification Network specifications. We can align to see if we're, aligned to the FHIR specification or the International Patient Summary specification or the rules on ICBP for yellow fever digital, vaccination cards. And that sandbox allows us to both build capacity and also test to see if these solutions are actually following the rules of the road, right? So in addition to that digital public infrastructure, that trust network that we get from the WHO, we're also testing to see if once we have agreement, once we know those use cases, are these actual systems abiding by the rules? And this is a really important piece because as countries agree to these rules of the road at the regional level, they've then started to replicate this process to shape their ecosystems at the national level. So for example, and you go to the right side of the screen, this is like where the magic happens, right? This is like 99% of the highway. The same thing that you have with the physical highway, countries have to build that road, they have to maintain that road, they have to continue to invest in that road, they have to update that road. The same applies in the digital Pan-American Highway for digital health. So there we're talking about taking some of the things from the regional level, applying what makes sense in their ecosystem, and then accelerating their construction. And again, testing them against those regional and international specifications. So when something is then deployed in Brazil, we know it can be also recognized and used in Jamaica. So these are some of the things that we're doing. And I'm happy to say that we have had 17 countries that are part of the initiative and our connectathons, meaning that 17 countries have been able to come together this is our 5th one this year in July, and do this, right? So we are actively negotiating the rules of the road. We're actively testing system conformance. We started off with 8 countries in Chile with the COVID-19 vaccination certificates, and now we're up to 17 countries. This year we'll be testing digital prescription. And next year we anticipate bringing in different types of tools for analytics that may include AI, for example, for secondary use of information, but following this big ecosystemic approach where it's not just one piece, it's really thinking about all the enabling environment that needs to be here so this can happen at scale. And maybe just 3 things to touch on. That inclusive digital health was agreed to as a priority and a policy and a core value as part of the highway. It's actually part of the inclusive digital health is one of the principles that all countries of the Americas have signed off on as the Information Systems for Health Plan of Action. So PH4H comes in and is not just something to say, but it's actually a list of specifications that we're developing so we can say, yes, this actually meets what the region has agreed to say, that it means that a solution is inclusive. So we're actively co-creating that specification right now. We also have a tool, a PAHO and IDB tool that looks at readiness for deploying AI across systems on the highway that's available online, and I can pop it in the chat if it's useful to people. And again, that foundation and governance piece we're actively working on. As I mentioned, we currently have an RFP out that's looking at what are the different models for regulation of AI as a medical device, AI as a software, emerging technology in general, and how those best practices can be applied on the highway. And really creating that space for regional coordination and policy and technical discussions. And I'm happy to say that through this project and with the help of Japan, the region was actually the first region in the world to emit digital yellow fever vaccination certificates aligned with the WHO specifications for ICBP. So this is the new amendments that were part of the IHR regulations, saying that we can now have paper and digital vaccination cards. So we were the first region of the world, recognizing here El Salvador and Costa Rica as the first countries who were able to do this. But 17 countries are technically now ready to do it. Now we're supporting them to move into production. And we plan on using this same mechanism and body to move other technologies forward and work with the private sector and public sector together to do that as well. So just to close here, definitely a long way to go. This is a huge undertaking. This is a massive infrastructure project, as I mentioned. But we will be having, we'd love you all to join us in Panama City, in Panama in July. If you are a government and you are interested in testing your system's conformance to see if it could go on the highway, we would love to have you. The Connectathon kicks off next week. We've just started our pre-Connectathon activities, and we'd love to see you there and also to learn from what you all are doing. And who knows, maybe we'll have a global Connectathon soon, and we can see how, you know, the Asian countries do at the regional level and the Americas do, and see how how we can raise the bar globally. Thank you.
Thank you very much, Jennifer. You know what? I'm thinking how I can bring more warmth in the room a while ago, aside from asking you to give a big round of applause to our speakers. So can you just check in to the person next to you and just say hello or hi? And thank you for just being here in this forum. It's so difficult to travel today, and I hope that you'll make the most of your time here in Manila. So now we move forward to our panel discussion to be led by Mr. Luis Viñals Torres. And one of our panelists can't make it in today's forum, so he just sent us his own presentation. So may I introduce to you the Head of Intelligence Research Digital Agency of Japan. Please give a big round of applause for Chikako Masuda.
Good morning, everyone. Thank you so much for having me. Due to an urgent family matter, I am joining you online today rather than in person. I apologize for any inconvenience to organizers. So I would like to invite you to watch a short video I prepared in case I was unable to attend at all today. So now I am here today not in my capacity as a government official, but as a researcher in digital public policy. And the perspective I want to offer is this: Japan is a useful mirror because it is confronting the challenge of demographic decline and rapid aging earlier than most countries in the world. So Japan has universal health coverage and has been advancing a national digital ID system. Last year, that digital ID was formally introduced into healthcare settings across the country, a significant step in connecting people to their medical information. That is a lens through which I hope you will receive everything that follows my videos. So could you start my video, please? Thank you. Iris Eyes. Okay, so maybe I should share my video now. Iris, can you share my video or you cannot?
Okay, so we're just having some technical difficulties. So we'll play the video later, and we'll have a fruitful discussion also as we have our networking break later. So now let's move first to our panel discussion. So may I invite our moderator, Mr. Luis Viñas Torres, and our speakers a while ago here in front to join us for the panel. So I hand it over to you.
Thank you very much, and sorry for the technical problems. Probably we should share, and sorry, Shikuka, for not being able to share your video. Maybe we will share it later for people to watch it. Now, I would like to invite, can you bring Dr. Miao, please, could you come here with us? Yes, together with Clive Tan from the Tang Tuk Seng Hospital of the Ministry of Health in Singapore. Then Madame Shikuka, if we can put the video on for her to be with us, together with Byung-Seong Kong from ADB. If we can all of you join us and try to grasp a phone, a mic, and test that it works. Please.
Yeah, it works. It works.
It works. Yes. Please. You can. Yeah, Byung-Gyo, please. Thank you. So, let me start to frame a bit the panel. I think we have plenty of time for questions to the panelists, and then for giving, I have few of them, and try to get more deeper into the conversation, and then we will give the floor to you. Then one of the things, let me shape a bit the rules here. I think we should frame the discussion, and I was writing a couple of principles to shape the conversation. The first is, what is the unit of analysis, no? And why I'm referring to that, because we talk about devices that improve the quality. We talk about, we later probably will talk about analysis done with claims data, but then we need to frame the discussion on AI a bit from a higher level, and where the performance of the systems, it has to end up improving health outcomes. Otherwise, what are we talking about? No. So the first is, when we are analyzing it, we need to look at the performance of the systems, and that should be our unit of analysis. The second is, sorry, I might look a bit academic here, but where AI fits in the theory of change to improve the performance of the system. Because when Dr. Miao was talking about the example of, through devices that we are putting in, we are making it, enabling the frontline provider to improve quality because it improves accuracy. It might improve access because it, people in rural areas can have better, can check through AI and have a better diagnostic and treatment. And also, it can also generate efficiency. But the issue is, to make this work later to improve access, quality, and ultimately outcome, there is a need to have a theory of change, which is the trainings, which is the investments, which I think is a bit missing, or at least I feel that is a bit missing in the conversation. So just want to share these couple of points as a reflection to shape the conversation. Now, this session is about political economy, about interest groups. Annie was referring to, okay, we have the developers of tools, we have the decision makers, ministries, we have the the workers, we have the users, and each of them has different interests, incentives, and power, no? And then I think we that's a bit what we should be focused for the panel. So let me start. Let me give the floor first to Clive, that has not yet intervened, and then our ADB friend. So the question is, I think, what is your reflections on what are the interests of stakeholders? In the case of Singapore, no, you have the ministry, you have a very vibrant private sector, you have a very vibrant private providers also, and also people. So what do you think what is driving the AI, and what are the interests of the stakeholders behind on what is driving the AI innovations in Singapore?
Thanks, Louise. And good morning, everyone. So I'm Dr. Clive Tan. I'm a public health physician. I work at the government level, leading a small health team at the Ministry of Home Affairs. I also work at the Tan Tock Seng Hospital to lead some of the population health work. And I also teach at the National University of Singapore. So, I mean, that aside, so what we are seeing right now, and related to a lot of what the speakers mentioned, is that AI in health is going to be a mega trend. It's one of those mega trends that will take many years to pan out. So like what Iris mentioned yesterday, we don't know how it's going to look like in 5 years, 10 years time, but we kind of have to keep up with the changes. The key challenge, and I know that in this room there's a lot of policymakers and researchers. Can I just find out from a show of hands, like who identifies with being a healthcare professional and provider? Like you're a doctor or a nurse or pharmacist. Okay, quite a few, not that many. And I can speak for this group is that this group is probably a bit overwhelmed. As a stakeholder group, they are probably becoming the bottleneck. Not that they want to be a bottleneck, but they are a bottleneck because they are busy, right? The doctors and nurses are typically very starved for time. But AI and healthcare is something that often is a national priority, right? Because many countries like Korea, they have a national AI plan. China has a national AI plan. And the AI plan says healthcare is going to be part of it, right? So doctors and nurses are not used to this, right? You think of like cancer treatments, you think of vaccines, you think of new antibiotics. It is the doctors and nurses saying that, oh, minister, we need this. Can you give us more money to do this, right? So, but this time around, the tables have flipped, right? The ministers of finance, minister for development, minister for digital is the one telling the health sector, you guys need to keep up. So because of that, the doctors and nurses, they are the slowest part of the system change, and they have become the bottlenecks. And they are not very used to that. They're not very used to that. So when we talk about power dynamics, we realize that the doctors and nurses want to keep up, right? For every doctor that you speak to that understands AI, there's probably 20 of them that don't. Right? So the ones that you're speaking of are the tip of the iceberg. But behind that person, there's 20, 30 other colleagues that have no time to attend training, no time to read up on AI because they are so busy with their daily work. So I'd like to just end off this part by saying that we need to also move from AI in medicine to AI in public health, right? Because you, the policymakers, can take a more leading role in AI in public health. And AI in medicine, the truth is that there are a lot of commercial interests, right? Doctors in private sectors, pharmaceutical companies, digital companies, they want to push AI in medicine, and they're working directly with the doctors and nurses on it. But AI in public health needs to be a system endeavor, and it needs to be something that policymakers want to drive. So I'll end off with a short thing to say about 80-20. Right, let's do an 80-20 effort, right? 80% of effort is on AI in medicine, but let's do 20% of efforts on AI in public health. Thank you.
Thank you very much, Clive. And I like you are bringing us to the real discussion and present it. Okay, let's not neglect public health on AI, which is probably what has been neglected in many reforms. And then the doctors, and then the commercial interest to work directly with doctors. And that's a very good point. I think that should trigger further reflections. Let's go now to our colleague Byung-Yo Kong from ADB. Okay, going back to Annie's presentation, all these stakeholders, and one of the, if I remember well, one of your slides is how to align that, no? And how are we understanding the let's say the stakeholders dynamics and how to align these incentives? Over to you. Difficult question.
Yeah. So I think one of the biggest challenges when it comes to AI adoptions and scale is that every groups are solving different problems, based on their own priorities and incentives. For example, developers like technology companies, they want to scale up their solutions quickly, and also they want to gain more data access to increase their performance, model performance. Hospitals, they look more on whether the AI solution can fit in their daily workflow and also can work for the doctors and patients. And whereas government should look more on the equity and public needs and trust, as well as like payers, they really look at the cost efficiency, value for money. So there are so many different incentives that is playing within the same systems. So the challenge is that this not always aligned, but the common thing that cuts across these different groups is that they all work for better health outcomes using the AI solutions. So the real success of AI adoption and scale really depends on understanding the priorities and incentives of these different groups and driving them to work together and aligning them to work toward this common goal of achieving the better health outcomes. And so that, this really has to begin from the designing the AI solutions and working very closely with different stakeholders to make sure that all their voices, incentives are reflected in the design, and eventually the coordination has to be there to shape the directions, goes towards that, what is profitable is also what is doing good and increasing the equity of this public needs.
Thank you very much, Byung-Yo. But one difficult question, maybe it's for the three of you, it's who should do that, no? Meaning everybody is interested into improving health outcomes using AI, but there is different incentives, we agree, but then who puts order into the house? But let me, if you allow me, Dr. Miao, to bring back to you. China it's really impressive performance on the adoption, quick adoption, and clear commitment of the government on moving that, which probably makes easier to answer these questions. Who? No, the government is the one. Is the one that has set the direction and is pushing for it and is putting resources and wants to make it happen and maybe does the referee role. But in China, of course, there is the doctors might resist or might favor the adoption of AI, no? Or also NHSA, the insurance, to pay for some things and not to pay for others. Can you reflect about this, when the National Health Commission or the government at large leads the role, how to take into account these different stakeholders in the system?
Okay, and thank you for your asking. I was working in the Center for Statistics and Information System for Commission National Health Commission, and I work in the investigation and service and health service. So I think the answer, I try to answer the questions. So I think China has, the government is focused on the welfare and we used to funding to support and to use some project to support AI advance. So I think you mentioned that the physicians and clinicians, they had their how to explain this, their burdens and their they may be focused on the efficiency of the how to survive for the physicians, and also some big hospitals, the physicians is in focus on the study and how to make the diagnosis is more efficiency and more science.
Let me reformulate the question and narrow it down. Two narrower questions. One is the government working directly with the developers to invest and to adopt these AI powered devices? And the second question also is doctors that are experimenting with AI, do they have incentives? Do they have research grants or something like that?
Yes, I think they have the mention to use the AI, especially in the grassroots AI, the physicians. I think the just the ability of our clinicians, they use the AI. Just I has introduced in some grassroots, their physicians use the robot of the diagnosis to help them to judge how to diagnosis and analysis the physician's disease.
Okay, thank you again, Dr. Miao. Let me go back to Clive. What do you think that are the risks? You describe a situation that commercial developers have an interest to work with doctors and to scale up and using quickly and probably to develop also for export later. But what are the risks? What do you see will be the risk if we leave it without coordination, without anyone trying to look at this higher end public good, no? And making it work for everyone? What would you see the risks?
Thanks, Luis. So there's always a good space for innovation and experimentation. One very practical tip from Singapore is that we are very small, right? So I think a lot of us, we also have some resource constraints. So ours is that we are small. So we try not to do everything first. Right. So to your point, when we want to pick up new science, we want to find out that it has worked somewhere else. And then we want to be fast followers, right? Fast followers is great because somebody has already made the mistakes and learned the lessons, right? What differentiates a good fast follower from another is the ability to implement and execute well. So for us, when we try to take on new technology or new processes, we are firstly finding out where it has worked. Maybe it has worked in the US, maybe it has worked in China. And then the doctors will say, okay, let's do this, but we do it better because we learned the lessons from the first person. But we try to focus on the execution and the implementation.
Thank you again, Clive. And again, going back to Byung-kyu, you mentioned a bit about the challenge of incentives and understanding well, and you have presented well. But following a bit the example of Jennifer, no, the Pan American, which basically is a regional standard setting and making that the systems work. Do you see, because you and me, we both are at the regional level, no? Do you see what is the role of the regions, regional bodies or institutions in terms of trying to bring some, you know, trying to point out the blind spots, like Clive was saying, the public health, AI for public health, or the understanding that moving it more to systemic solutions rather than just personal care, individual solutions. So what will be the role of regional institutions like us?
I think regional institutions like us can serve as a platform because it has a very strong convening power. Because one of the important thing in terms of AI adoption is that to avoid misalignments so that everyone gets the equal access to these benefits. And one of the risks of AI is that it tends to benefit those who are already ahead. You know, in many cases, benefit first goes to the places where they have strong capacities, like, for example, large hospitals in urban areas. They have the infrastructure, skilled staff, and data to actually utilize the AI, whereas rural clinics or low resource settings, they don't have sufficient connectivity or data or skills. So I think as regional institutions, we have to make sure that these misalignments, which could create having people with the insufficient infrastructures to left behind, can also be included in this benefit of AI adoptions. That can be done through policy and partnership, and encouraging them to focus more on these underserved populations.
Thank you very much. I'm being called to wrap up, and I promised 4 minutes to Dodo. He asked me 3, but I'll give 4. But before Dodo, just a bit a final conclusion. Do we have time for questions from the floor? Yes. So, but before, 2 reflections. One is, well, my perception, and I might be wrong, but this is I think there would be a common agreement that we are building the boat while we are sailing. I don't think that hearing all the panelists but actually yesterday also, we are not yet, you know, the house that we are collectively building, we are just having few pieces, and some are faster than others, but the house is not there at all. And I think that we need to recognize that we are on this uncomfortable situation and bear it and try to improve it. And the second is, I want to bring the equity part of the discussion, no? Because the potential is there, and you know, there is example when we are strengthening the capability of a frontline worker in places where a doctor will not be there for the next 30 years, and we are increasing access, we are increasing equity. And that's quite an easy example. But I think that the discussion about equity is still we are not putting it at the center, my perception. So with that very unconclusive wrapping up, we would like to have how long we have for the presentation now from Shikuka is Shikako.
Yes, thank you so
Okay.
much, Chairman, and thank you giving that another chance. Thank you very much. And the audience, I'm so sorry about that, the technical issue. So we had the checking, but it doesn't work. Okay, so I'm gonna share my screen now. Okay, can you see now? Can you see my screen now?
Yes, very well. Thank you for your patience.
Okay, perfect. So good morning again from Tokyo. My name is Chikako Masuda, Head of Intelligence Research of the Digital Agency of Japan. I have just 5 minutes, so quickly I want to do the presentation. So today I am here today as an academic researcher in the digital public policy. So not the pleasant finished answers. So let me start with a simple question. Will AI make a healthcare more equitable, or will it deepen the divide that already exists? I believe the answer depends not on the technology itself, but on how we design the system around it. So I want to share a framework for thinking about this and some concrete data from Japan's healthcare DX journey. So this question is often framed as a technology challenge. If we build better models, faster diagnostics, more compute, the problem will be solved. But I want to propose a different lens. So Japan, I mentioned, we have 1,700 over local governments, and each local government, each society has a different medical situation. So consider what actually determines whether AI works in healthcare settings. Is there someone in the clinic who can evaluate it, or can citizen use the digital device fluently? Is there even a clinic nearby? So when you look through this lens, the real question is not whether AI is good enough. It is whether the society receiving it is ready. So this is the design problem, and the design is something we can influence. So why doesn't AI simply scale on its own to these social issues? So let me name 3 structural barriers. The first, data fragmentation. Second, workforce gap. Third, the governance deficit. So these questions are unanswered in most contexts. The result is predictable. AI succeeds where infrastructure already exists and fails where it is needed most. It is important to note that AI does not function neutrally. So where conditions are ready, it amplifies quality. So where they are not, it risks amplifying inequality. To structure this discussion, I want to introduce the concept of AI readiness. So readiness has 3 dimensions. So this is depends on the Japan situation. So maybe another dimension you will about or imagine. So data readiness, institution readiness, and human readiness. So these 3 must develop together. Advancing one without others creates bottlenecks. AI is not standalone tools. It is an ecosystem technology, as other presenters mentioned, and the ecosystem require all parts to function. So I want to share Japan's situation as one example. This is not optimistic, the data, but I think that this is not unique, but perhaps similar for challenges many countries going to be facing in the future. The 3 structural realities in Japan correspond directly to the 3 dimensions of AI readiness. The first, aging. Nearly 30% of population is ready over 65, heading towards 35% by 2040. More than 1 in 10 is now over 80. This is a human readiness challenge. The second, fragmentation. Over 100,000 clinics nationwide, over 38,000 individually owned, 95% without inpatient bed. Each standalone unit, limited IT capacity. This is a data readiness and challenge. And also those hospital, those clinic are supporting to the local government healthcare. The third, the sustainability. Nearly 600 clinics closed in 2024 in Japan, a record high, the primary due to physician aging and no successors. It's going to be happen to the another country also in the near future. That this is on institution readiness and sustainability challenges. This is why adoption is not the hardest part. Integration into this distributed, resource-constrained aging system is. So look at what Japan case tell us about the readiness, specifically this gap between policy ambition and structural reality. Japan government has set clear targets under the Medical DX Vision 2030 roadmap, EHR adoption at 80% by 2026 and 100% by 2030. But the current situation is striking. As of 2023, only 55% of clinics had EHR compared to 94% of large hospitals. The more telling, when the Japan Medical Association surveyed clinics still using paper records in 2025, 54% said adoption was simply impossible for them. Because of no IT staff, the doctor is elder and no financial runway. So those complicated situation is happening in Japan, and across all clinics, 94% say they lack anyone in house with IT capability. So the government is pushing from the top, and the clinic cannot move from the bottom. Those kind of situation. So that space in between is where readiness lives. So this is a policy practice gap, I think. So let me close with 3 areas for action, the things we can pursue together across countries. So Japan is a case is instructive. The first, shared framework. We need a common language for AI readiness so that local government or hospitals can assess themselves, compare progress, and learn from each other. EHR adoption rate tells a very different story depending on whether you measure it against the government target or the structural barriers facing over individual clinics. The second, knowledge exchange, including failure intelligence. This is very important. The third, AI as public good. Data and models built with public resources should be shared as public infrastructure. So the technology will involve rigorous. What we can influence is the design of the systems that deliver it. So how we design matters more than what we build. So thank you so much for giving me the second chance, and thank you very much.
Thank you very much, Dr. Chikako. It's extremely interesting. So how long do we have still? 5 minutes. No. No questions? Okay. Sorry, we will need to use the coffee break to approach the speakers and to have your questions. It's thank you very much, Dr. Chikako. I think it's great. You have brought in my view, 2 great points. One is to check to the societal readiness, and I think that this point is a bit overlooked. And the landscape of Japan in terms of aging society plus health workforce, both aging but also a shortage in other countries, it's a reminder. One of the points the one that I make at the very beginning, the assistance view is needed. This is not. We need to put the AI introductions within assistance with the current level of performance, which AI can amplify if it's not designed properly. So it was a really very interesting intervention. Thank you again, and thank you for your patience, Dr. Chikako. I would like now to invite Dr. Eduardo Banzón, the Director of Health, to have his final reflection/remarks on this boat that we are trying to build while we are sailing. Dodo, the floor is yours.
Luis was my AI. He was my avatar, and I was planning just to sit down and do. In a sense, let's reflect on the presentation because this is about the political economy of AI and how it can actually be accepted. I think the first thing we need is, if you listen to the presentation, part of the problem we have why AI is sort of misunderstood is it has become a magic bullet, right? The word itself is presented as if it's a new solution, right? And it's a bad word. I'll go to that later. And if you listen to the presentation, it's really nothing more than an extension of a lot of the digital health work that we've been doing. And a lot of the concerns and the things we need to do to make sure digital health standards, data privacy, all of that are key. If a country is weak on standards, like the Philippines, still no data standards, sorry, I just love to talk about the Philippines. Hopefully you could resolve that soon enough. Then you'll have a problem, right? If data privacy is not something that is embedded within the country system, then you have a problem because once you start doing AI, then that just adds to it. So in a sense, we need not to dissociate AI from the whole digital health innovations that a lot of us has been working on. If the second point is AI, it's a bad word. I never liked the word artificial intelligence. Because when you start using the word artificial, that means you're being replaced, right? Artificial sugar, artificial friends. Yeah. Artificial is... But admittedly, if our friend from China presented from the National Health Commission, it's really augmenting. It's really augmenting intelligence. If you think about it, I probably should change the word and call it augmented intelligence. It's essentially augmenting so that when we work and see our patients, right, we have better skills. You know, when I'm a medical doctor, so Clive asked that question. And we always like to claim that when a patient comes, you know, we can immediately say what that patient is sick of. That was AI, before AI, right? Because now AI takes a picture. We always say, Iris is from PGH, Eloy, we're from the Philippine General Hospital. And we claim we're better doctors because we saw so many patients every day. That's AI. Because if you think about it, it's because they keep on having all of this data, and before you know it, they become so good. So in a sense, if it is presented in a way that it will augment, as presented by our friend from National Health Commission, then it's not going to be a threat. If you present it as an artificial replacement, it's, you know, artificial is a bad word. So maybe it's the framing. Because if you start talking to medical doctors, then they start thinking, I will be replaced. When that should not how it should be presented. And in the political economy of AI, if we do not fix that language, the term will have a problem and the doctors will resist. But if we start telling them, no, this will allow you to see more patients, the Philippines charge more patients. If you go to provincial, if you go to public health, it will allow you to look, how do we get data in public health before? You know, we have to go, you know, we have to look into the records and everything. Now, you know, this will allow you to watch more Korean novella, sorry. Because now you have more time. Work-life balance will be easy because, you know, then, so maybe another term we should call AI is adaptive intelligence. This actually allows you to adapt to context, allow you to handle surges, right? So, frankly, I refuse to use the word artificial intelligence. Sorry, my colleagues from DIG, because for me, these are, we call them DIG in ADB, the digital, right? We dig. Because it just sends the wrong message. Okay, so third, and this is what, so what's first, second? Okay. Third, and this is the last part, okay. Because, you know, we are Asian. I am avoiding them because there's no female there. So I'm not part of this all-male panel, okay? That's why I'm trying to avoid it. I will go down now. Okay, I am not part of this gentleman, okay? Sorry. So I'm here, okay? So, and the last part was our friends from IADB, right? The Inter-American Development Bank. Although I think we need to visit them, right? to see what they're doing. ADB is a multilateral organization. I always tell people the DNA of ADB is essentially countries helping each other. We were established 60 years ago. WHO is older, but I used to be there until I decided to become younger. So, because we are supposed to help countries, we're supposed to make countries work with each other. And I'd like to emphasize this point because we're now living in a world where there are some push for countries not to work with each other. And the presentation of PAHO, IADB, was so powerful, right? Because in a sense, during the pandemic, we were really challenged about this concept of digital vaccine certificates, or I'm a UHC guy, like I love to call roaming universal health coverage. I used to say the word universal did not say universal only in Japan or only in Korea. Universal means all over. But in Asia, we don't have that coverage where you go from one country, you have to buy travel insurance, right? So the sole idea of having UHC across borders, right? Surveillance across borders can actually be driven if we do the elements as they describe, which are elements needed for AI. Again, common standards, right? Common rules, and all that. So, and of course, the challenge, if countries cannot even do it among themselves in a country, that becomes a problem. Sorry, Philippines. I have to say it again. Please, let's have your common data standards tomorrow. Because unless you have that, then it's difficult to get countries to talk to each other. Latin America is showing they can do the way, right? And frankly, do you actually believe, if you're in Asia, that Latin America has better highways than us? No. Asia has better highways, right? So I look forward that we in ADB will also have the Asian Digital Health Highway and Seaway, because and airport, because we also fly. But in a sense, it just shows that if you use digital, if you use AI as a tool, we can actually do a lot of things. So I think I stop there, and thank you very much.
Thank you very much, Dr. Banzon. Thank you very much, Luis, and all our panelists. But may we request you to please stand for our group photo. And Dr. Banzon, can you join our panelists and our speakers for this group photo? While we are waiting for the group photo, we're flashing the QR pulse for you to scan, share your thoughts about our session, and let us know what else you would like to learn in the latter part of our meeting. Would also remind everyone that for you to please do not forget to get your food stubs later during our snack break. We'll ensure you that you'll get your lunch if you surrender your food stubs. Are you all enjoying our session? Thank you very much. I can see more smiles now than earlier. We look so formal and very, very strict. Okay, once again, a round of applause, please, for our speakers, our panelists for today's session. So now we will have another group photo for all of us here at the auditorium. Please stay, and we will call our photographers to take our group photo. So please fix your clothes, your hair, because all of the photos which will be used in this forum will be shared by the WHO and ADB for the purpose of this meeting. Okay, so get ready with your smiles, fix your clothes. If you have anything beside you, some bags, bags or laptops, please fix it accordingly. Okay, may we ask those people sitting at the last 3 rows to please stand so you will be more visible to the camera. Last 3 rows. Yes, please. More people sitting at the right side, please stand.